Welcome everyone to this afternoon's webinar, RAND 4.0 report, what the hospital price transparency study reveals about Kentucky and Southern Indiana. This report, released recently by the RAND Corporation and the Employers Forum of Indiana, contains a wealth of information about hospital prices across the country. Before we begin the program, I want to briefly turn it over to Kentuckiana Health Collaborative's President and CEO, Jenny Goings, for some opening remarks.
Thanks, Stephanie. And as Stephanie said, I'm the President and CEO of the Kentuckiana Health Collaborative. Very honored to be in that role. Prior to this role, I was the Commissioner for the Kentucky Employees Health Plan. And I think many of you or most of you probably know that. And as Stephanie and I, primarily Stephanie, were preparing for today's presentation, I started thinking about just transparency in general, because there's so much going on in the healthcare industry right now related to transparency. So I wanted to share a story as we get started. When I was the Deputy Commissioner and then Commissioner of the Kentucky Employees Health Plan, we had a gentleman come in and talk about a new program that his company had launched out of New Hampshire, and he spoke to our board about it, and it was about transparency. How to add transparency to the healthcare space to allow patients or members to shop for services. And it sounded so simple, and it was. And one of our board members, I loved to always share this story, one of our board members stood up and said, "Hey, don't let that man leave the room until we make a commitment to join his services." And at that time, that was called Compass. It's changed hands a couple of different times. It's Smart Shopper. I'm not here to sell that program at all. What I am here to say is this was about 13 years ago or so, give or take a few years. And even though it's not that easy to sign on a product or a service when you're with a public health plan, the thought of adding transparency to our members, even our board said, "Hey, we need to do this." And that was about 13 years ago. And a lot of things have happened since then. A couple of stories to share with just our experience at the Kentucky Employees Health Plan with transparency. And I've seen some of this happen throughout the country even. We had members, I would have members come to me and say, "Hey, I want to get this particular service, but it's not on the website to be shoppable," because there were a list of services that we had claims data on, and that there were distinct differences in cost by providers that we would list as shoppable, and we would incentivize people if they went to that lower cost. Quality wasn't in play, but lower cost facility. And again, I would have members come to me and say, "I can't shop for this service. I want to be able to shop for this particular service." And there were reasons why at the time they couldn't. You know, one of the things that we were told when we implemented this program was, this is going to be a mess for providers. Providers won't like it. They're going to start raising their prices. We saw just the opposite. Providers would call in to our third-party administrator and say, "I want to lower my price, my negotiated rate, so that I can show up on," the tool was called Smart Shopper, "so that I can show up on the website as a lower cost facility." I had many members come talk to me about they would sit in the same parking lot and get their annual mammogram, which was zero cost to them. But they were thinking about, we were finally starting to have some conversation around consumerism, and they were saying things like, "I'm sitting in the same parking lot and going to a lower cost facility by going to this building versus that building." And so those conversations have been happening for years, and it's a positive thing. RAND 4.0 that Stephanie is getting ready to talk about, and she'll share the history of that, so I'm not going to steal her thunder. But it started because hospital prices in Indiana were so high that there was concern about, how do we bring down cost? And this started in Indiana. And so being able to understand cost, not making a judgment about whether the cost is right or wrong in my statement that I'm making right now, we can talk about that as a group, but being able to understand the cost, bringing transparency to the discussion, is extremely important. And because providers, insurance companies, employers, we've all struggled with this concept over the years, and we've not made a lot of inroads ourselves about adding transparency to the discussion. The federal government has stepped in and said, okay, enough is enough. These are my words. Enough is enough. We need to make sure transparency is out there. So we have the RAND study, and I'm sorry, Stephanie will talk about where that RAND study is taking us. But then we also have the federal government saying, hospitals, a couple of years ago, hospitals, you need to be posting your costs online. And now, as of July 1, employers have to be posting the cost of different services on their website, on their TPA website, et cetera, but they need to be posting that information. And then by December, employers need to be posting information about health plans, very similar to how several years ago, I want to say this is in the 80s, but don't quote me on this particular fact, but many years ago, we did a similar process with ERISA plans related to retirement benefits. And that was to put in transparency related to all of the different costs. And then also not just put in transparency, but then some rules and regulations about what should you be spending money on? How do we make sure that members who are in these retirement plans are confident that they have a value added retirement plan when it's time to retire? Those kinds of laws related to ERISA retirement benefit plans are now being implemented for health plans, and fiduciary responsibility is coming into play more than it ever has. So I just wanted to take a minute to share with you just some thoughts around this whole concept of transparency, being able to shop for services. I don't think that everything that we're doing and everything that we're going to be talking about today in the RAND study is helping members of health plans know how to shop for services, but it is taking us in the direction of, as providers, as insurance companies, as employers, being able to know that we need to be looking at real data. We need to be looking at and understanding cost, because as costs continue to rise, and they are, and Stephanie will share some data on that, and we're in the trillions, folks. When we talk about healthcare, and healthcare is part of the American or U.S. Gross domestic product, we're pushing up against 19% is the healthcare spend on the U.S. gross domestic product expenditures. That is just craziness. And I know all of you agree with that. And we may not all agree on how we get to where we're looking at managing these costs, but I do believe that the RAND study and other transparency avenues that are out there, either because we've chosen to make sure we have transparency information for members who are on our health plans, or we're being encouraged and even advocated is not the right word. We're being required to do so by the federal government. Understanding the information is critical. And Stephanie is one of the best I've ever seen at taking the data that is out there and helping us understand it. So I'm going to turn it back over to Stephanie. Please feel free to ask questions. You have the chat. You also have the Q&A box. Feel free to jump in and ask questions. And today's discussion is about educating us all, because we have not near the issues that Indiana had when it started, but we still have some avenues for improvement when it comes to Kentucky. So Stephanie, as the expert, I'm going to turn it over to you now. Again, just wanted to encourage all of us to think about that transparency piece as we have all of these discussions, so that all of us, whether we're the employer, we're the insurance company, we're the provider or the hospital system, we're trying to figure out a way to help those patients, those members, be able to understand their own healthcare costs.
Thank you, Jenny. And as Jenny pointed out, this is just one piece of a larger transparency picture. So we're kind of narrowing our focus today on one study one iteration of one study in one area of focus, but it is a larger conversation that we'll kind of touch on at the end as well. An hour might seem like a long time, but anyone who's familiar with the study can assure you that there is no way to convey all of the information in just 60 minutes. So today we are going to focus on the big picture of what this study reveals about hospital prices in our region, as well as upcoming plans, events, and tools related to the RAND studies and transparency more generally. We should, as Jenny said, have some time for Q&A at the end. So be sure to utilize that Q&A feature on Zoom, and Jenny and I will be on hand to answer some questions. I don't know that I told Jenny I'd bring her back for the Q&A portion as well, but Jenny, you've been warned. So without further ado, let's dive in. Some of you might be familiar with the price transparency studies, but to level set today's conversation, let's talk at a high level about the study, its background, goals, and general observations. Why are we here today, this afternoon, on this webinar? First, employers play an important role in the U.S. healthcare system, both in financing healthcare spending and in selecting health plans to offer to their employees, covering half of Americans, about 160 million people. In 2019, spending on hospital services accounted for nearly 40% of total personal healthcare spending for the privately insured, or $434 billion of the $1.2 trillion total healthcare costs in 2019. Estimates indicate that number will continue to increase. Employer premiums have risen, and so has the amount that employees contribute to care for themselves and their families. This graph shows the growth in average annual worker and employer contributions to premiums for single coverage since 1999. Even, comparing to 1999 is kind of tough with inflation and such. Even just looking back at the last handful of years, total premiums have risen from less than $6,500 in 2016 to nearly $7,500 in 2020. Meanwhile, the increase in workers' earnings has not kept pace with the rise in deductibles and family premiums, which have outpaced overall inflation rates. When families spend more money on healthcare, they have less to spend on other necessities. This slide is a couple of years old since the last time I updated it, but I include it because it's a powerful visual of how a family budget is impacted when the cost of healthcare rises. So that's the challenge that we're facing. None of that information is new. Even if we didn't know the exact numbers from the previous few slides, as many people don't know that, anyone who works in healthcare or HR could tell you that healthcare costs continue to rise year after year. Because employers are such a large purchaser of healthcare, representing 160 million individuals, the Employers Forum of Indiana, KHC's sister coalition in Indiana, and the Employers Forum of Indiana, an employer-led healthcare coalition comprised of employers, physicians, hospitals, health plans, benefit consultants, and other interested parties, which, spoiler alert, is everybody's an interested party in healthcare, started to look at, what that first slide showed was a large part of total healthcare cost, hospital prices. The forum's members thought they were paying too much for hospital services, but they didn't have the data to back that up. So they started looking at the problem with data. And in 2017, the forum began working with the RAND Corporation, a nonprofit global policy think tank, to gather data to see if they were in fact paying high prices for hospital services in the Hoosier State. For the pilot study in 2017, Indiana employers submitted data to RAND on fees that they had paid hospitals for their services. That initial study included data on about 225,000 covered lives, and they found that for each dollar that Medicare would have paid for those same services, Indiana employers were paying $2.72. But how would Indiana employers know that that $2.72 was high if they didn't know what was being paid in other states? Therefore, the study was expanded, and you can see on the screen that we are now on the 4th iteration of the study, which includes data on 49 states and Washington, D.C. It now includes data not just from employers, but health plans and state all-payer claims databases from 11 states. The scope of what is looked at has continued to grow each year, as well as how prices are looked at. Speaking of how prices are looked at, I want to take a minute to look at what this study actually examines, which I hinted at in the last slide, but want to explicitly define here. The RAND Hospital Price Transparency Study looks at hospital prices in 2 ways: relative prices and standardized prices. Relative prices are the ratio of the actual paid amount by the private insurer divided by what Medicare would have paid for the same services provided by the same hospital. Relative prices have the advantage of incorporating all of Medicare's adjustments for case mix, local wages, and inflation, and are comparable across service lines. The Medicare algorithms adjust for things, like I just said, like case mix, local wages, teaching hospitals, and uncompensated or charity care. Standardized prices are the average allowed amount per unit of service, where services are standardized using Medicare's relative weights. They are not comparable across service lines. So I want to note that in today's data presentation, because of limited time, we will be focusing on relative prices as we compare our region to others and look at higher level data insights. If you've attended any of our previous forums or any of our previous webinars of this, you'll know that we typically do focus on those relative prices. There are several reasons why RAND chose to look at prices compared to Medicare for these studies. First, because Medicare methods are adjusting for things such as case mix and local wages, and we're able to compare on an apples to apples basis relative prices between states, between hospital systems, etc. As you can imagine, $1 spent in a hospital in California is very different than $1 spent in a hospital in Kentucky. These methods are empirically based and they're transparent, which means that for the study, the researchers are able to recreate and simulate what Medicare would have paid for those services. Medicare prices are designed to provide modest profit margins for efficient hospitals, so the comparison is reasonable. Another benefit to these studies is that they look at what is actually being paid to the hospitals by the private insurers, not just what is being charged through claims, which as we all know is not often what ends up being paid. Since 2017, the set of data that's being contributed has continued to grow. And where at first, as you saw on the previous slide, only included, or previous 2 slides, and where at first only included employer data, now includes health plan data and all payer claims database data, which is a wealth of information. Each iteration of the study includes data from the most recent 3 years. So the study that just came out includes data from 2018 to 2020. Similar to the nation as a whole, Kentucky and Indiana's overall relative price to Medicare increased from 2018 to 2019, but then decreased from 2019 to 2020. In 2020, the overall relative price for the United States was 224%. This means that participants in the study who contributed their data to the study, those health plans, those employers, those all-payer claims databases, paid more than twice what Medicare would have paid for those same services. A couple of things, if you're familiar with previous iterations of the study, a couple of things that are new to this year that I just want to call your attention to. We'll talk about a couple of them in today's analysis, but not necessarily all of them due to time. COVID-19 hospitalization information has been included. More data from all-payer claims databases. The previous iteration of the study only included all-payer APCD information from 4 states. We're up to 11 now. Largely because of that APCD data, we now have ambulatory surgery center data as well, in addition to the hospital data, and leapfrog safety grade data for the quality piece, along with what we've always had is previously is the CMS stars ratings, which we still have that, but we've also added some leapfrog safety grade data as well. So before we get into some of the specifics of the data and what it means for our region, a couple of key takeaways that RAND has identified in their report for the nation as a whole. Similar to the previous studies, there is wide variation in hospital prices, both across states and within states. Throughout the nation, overall relative price relative to Medicare ranges from 147% to 321%. And as we'll see in the Kentucky data as well, there is variation within states as well. Facility fees are much higher than the professional fees side of the overall fees. Prices for those ambulatory surgery centers, or ASCs, are lower than hospital-based outpatient departments. And prices for COVID hospitalizations, inpatient stays mirror inpatient prices. Before I begin to dive into the regional results of the study, I do want to note that the study and supplemental data is available for download for free at the link you see on your screen. The supplemental data is in form of an Excel workbook with tabs for each state, system, hospital, service line, you name it. And that's where the data for today's presentation has come from largely, with a couple of other supplemental items to kind of set the stage. So I will share these slides and a list of resources like this link after the webinar. I thought about putting in the chat as we go, but it would just be too much. So we'll put that all together and email it to you after this presentation. And before I begin, I just want to call out to Jenny and Natalie from the KHC on our line. I see we haven't even gotten into the Kentucky data yet, and the Q&A function is already lighting up, and that's kind of what I expected. But if you guys could take a look at those throughout the presentation and maybe like highlight a few that we can start with on the Q&A portion, that would be really helpful.
Okay, we definitely will do that. And any that we can answer quickly, we will do that just so everyone knows. But definitely some really good discussion items. So continue adding those questions in, because we will try to get to as many as possible, but several of them are related. So we'll be able to have a good discussion in that area, just so you know, Stephanie.
Perfect. Thank you so much. Okay, with all of that background out of the way, let's see what we're all here for today. And that's to see what the data says about our region. Of the 49 states, plus DC, with enough data to report an overall commercial price relative to Medicare, Kentucky ranked cheaper than the national average at 212% in 2020, compared to the national average of 224%. The report shows prices as a percent of what Medicare paid for the same services, thus making these relative prices comparable across the country. I do want to note that Kentucky's inpatient prices were 203% of Medicare and outpatient prices were 222%, which I don't believe is on this slide, but it will be in subsequent slides. So one thing that I did want to note, the scope of the 2022 study. I say 2022 study because that's when it's released. Of course, the data comes from 2018 to 2020, and it's often referred to as RAND 4.0. I do want to note that we had $261 million of total hospital spending in Kentucky in 2020 in this study. That is a reduction, what I thought was interesting, that is a reduction in the overall dollars spent from the previous study, which included 474 million. So considerably less dollars spent, but as you can see, the number of facilities that had enough data to report either an inpatient or outpatient score or an overall score has stayed roughly about the same. So despite the less overall dollars contributed to the study, we do have the same number of, or similar number of hospitals and systems represented in the data. So of that 261 million in hospital spending in Kentucky in 2020, as I mentioned on a previous slide, Kentucky's overall rate was 212%. So what that's saying is a little more than twice of what Medicare would have paid for those same services at those same hospitals. So Medicare would have paid 123 million for those same services. And let's say, hypothetically speaking, the private payers, the private insurers in Kentucky reduce that number, reduce the amount paid to what Medicare would have paid. That would have reduced 138 million in healthcare spending if private prices were the same as Medicare. Now, is that the fair price, 100%? I'll talk about that in a minute. I'm not sure that that's the case, but that's just, to give you an idea of kind of what Kentucky's private insurers are paying for these services. This year's study covers the whole state, like I mentioned, about the same as previous years. The size of each circle represents the amount of payments included in the data. And the color red, green, yellow represents the price. So Kentucky ranks 12th lowest in price of the 49 states in Washington, D.C. I'm just going to start saying 50 states instead of qualifying that each time in the study. In the previous study, Kentucky ranked 6th of the states in the study. So it has gone up a little bit in the rankings, but still the overall relative price, as we've noted before, is below that United States rate. But in a nation of high healthcare spending, just because we're below average doesn't mean that's necessarily where we want to be. Healthcare premiums for the average American family with employer-sponsored insurance is around $21,000 per year, $15,000 paid for by the employer, and about $6,000 by the worker. Kentucky's total family premium is similar to that national rate, as you see by those two bars that look pretty much identical in height, but it represents a larger portion of household income at nearly 40% of the median household income. So average does not mean equal family burden in this case. The slide you see on your screen has been rolled up by system. So for example, all Baptist health facilities are shown as one column on the bar graph. You can definitely download that supplemental data, or I can share with you offline some of my other graphs, but with 76 facilities, the slide looked a little crazy. So just to illustrate the variation in Kentucky, I did roll those up into systems. And as you see, the overall price relative to Medicare ranges from 118% of Medicare at the low end to nearly 300%, 292% at the highest. 12 of the 20 systems that you see on the screen that we have data for are below the national average of 224%. If you did some quick counting just now, you might be saying, but Stephanie, there are 22 systems shown on this graph, not 20. I do want to note that's because independent facilities have been grouped together in the data as well. I have highlighted in teal the independent systems bars, one indicating hospitals paid under the inpatient prospective payment system, and the other indicating critical access hospitals. There are 6 of those critical access hospitals and 8 of the inpatient prospective payment system. And then looking just at inpatient stays, Kentucky systems ranged from 91% to 212% for an average of 206%. Again, under the national average, similar to the overall prices. And again, those independent hospitals are combined and indicated in teal. And for outpatient services, Kentucky's systems range from 163% to 420%. So we're seeing a lot of variation here. That's an average of 241%, which is actually higher than the national rate of 231%. This is, I'm fairly certain this is the first year of the study that Kentucky's outpatient rate has been higher than the national rate. So in a lot of these upcoming slides, I've added some slides to look a little more closely at outpatient rates in subsequent slides. Kentucky looks good compared to our neighbors in overall price, as well as inpatient and outpatient relative price. West Virginia, that you see on the right there, with an overall relative price of 317%, actually has the second highest overall relative price in the US, second only to South Carolina at 321%. Again, recognizing that Kentucky has a slightly above average outpatient rates, not seen in previous studies. Here we've highlighted outpatient relative price. Kentucky and its neighbors, as you can see, are all above the 231% national rate. Kentucky's outpatient price, however, is still lower than most of its neighbors, with the exception of Tennessee to the south, where our present CEO, Jenny Goins, actually lives now. But let's zoom in a little bit on our border communities to get a clear picture of what's happening with our bordering neighbors. First, we're going to look at Northern Kentucky. Looking at Northern Kentucky, in many instances, overall prices are lower in Cincinnati. So if I live in Northern Kentucky, I might be inclined to cross the Ohio River for some of my healthcare needs. These groups of hospitals are very close to each other physically with different prices. Okay, and now if we zoom in on Kentuckiana, Louisville prices are a lot closer to Southern Indiana than what we saw in Northern Kentucky. I know that you can't see all the labels here with the mapping program I used. Some with the dots being close to each other, they wanted to remove some of those. We'll have them back up in some subsequent slides. But and you also might have already noticed the color key on the right. And I just want to point out that in the RAND study, they classify lower cost at a lower price, as less than 150%, higher price as more than 250%, and everything in between as that middle ground. So for consistency, we'll see that in any visualization where color buckets are used, we've used this definition as well. As Jenny might have mentioned, as Jenny definitely mentioned in her opening remarks, and I mentioned earlier, there is a much larger question of what truly is a fair price relative to Medicare and what those buckets should be. which I'll talk about later. But again, for consistency with the RAND report, we're staying with this definition of less than 150, 150 to 250, and more than 250. So going back to what this map is showing, although all of these facilities are yellow on the screen, mid-range, the 150 to 250, that's a pretty large range. 169 for Baptist Health Floyd in Southern Indiana versus 201% for Baptist Health LaGrange east of Louisville highlights that there is still variation in this area. The variation is even clearer in outpatient prices, which are sometimes more shoppable than inpatient prices. Staying in Kentuckiana for the moment, prices for outpatient services range from 115% to 283%. In Northern Kentucky, you see similar trends as you did for the overall price compared to Cincinnati. I'll just pause on some of these so you can have a moment to take it in. In addition to overall combined facility and professional fee prices, RAND separated prices by component: inpatient facility, outpatient facility, and professional fees. Now, if you're familiar with previous iterations of the report, they used to have an overall facility fee, but they seem to have discontinued looking at that combined rate, and they separate by inpatient and outpatient. Facility fees account for approximately 85% of a total hospital bill. This chart presents the state level variation in the three price components. Overall, there is less variation in professional fees than there is for either inpatient or outpatient facility fees. In most states, professional fees are below 200% of Medicare. Kentucky, highlighted in the orange box, has some of the lowest relative professional fees in the country. The study also looks at several outpatient and inpatient services. I do not have time to highlight all of those today, unfortunately, although I've looked at most of them and found some interesting things. Hopefully we can start to use that data maybe for other programs and events. But I did want to note that if you do download that supplemental data, you will find information on outpatient services such as ED visits, PCI, endoscopy, laparoscopic surgery, and CT MRI, as well as inpatient services such as orthopedics, substance use and mental health, circulatory system, and respiratory system. So let's take a look. Like I said, I don't have time, unfortunately, to look at all of these services, but we have grabbed a couple to highlight just to show you some of the variation that we see in the Commonwealth and in Southern Indiana. So first, emergency department visits. Kentucky's facilities range from 153% of Medicare on the low end to nearly 800% on the high end. I double checked that data because that was, those last couple seem like really large outliers. But as you can see, there is a lot of variation throughout the state. Staying with some outpatient items, CT MRIs, there is also variation there. Kentucky's facilities range from 96% to about 650%. Variation isn't just within the state either, it is also within regions. The last slide was helpful, but if, say I live in Louisville, would it be really worth my time to drive to Lexington for an MRI for a cheaper price? That's doubtful. But driving to another facility within that same city, much more likely. So here you can see the variation in CT MRI services just in the Kentuckiana region, so that greater Louisville, Southern Indiana region. Lots of CT MRI data, as you can probably guess, in this RAND study. So I chose that just to illustrate that you do see a lot of variation within cities, not just within states as a whole. Similarly, in the Lexington, Winchester area, CT MRI services range from 202% of Medicare to 383% of Medicare. And I mentioned at the beginning, when I was talking about the RAND study overall, the inclusion of ambulatory surgical center commercial prices. And this is something new to this study. This is not something that I have a lot of detailed information on for Kentucky, but this graph, which can be found in the report, shows that ASC relative price ratio, and I've highlighted in orange Kentucky, which is again on that lower end of the spectrum. And as we have found nationally as well, ASC services are relatively lower than hospital-based outpatient. Okay, with this slide, I think we're running right on time. With this slide, we start looking at quality, as this was a big conversation of the last study that was released in 2020 as well. As highlighted in last year's or 2 years ago's report, Kentucky's hospitals lag in comparison to the rest of the study, excuse me. Fewer Kentucky hospitals in the study have above average or excellent CMS hospital ratings than the rest of the country. Just 25% have a 4 or 5-star rating compared to 43% of all hospitals in the study. So some negatives and positives. The gap in percentage of 4 and 5-star hospitals has widened, but last time we had no 5-star hospitals in the study, and now we have 5. The goal is to find the best value, highest quality, and lowest price. One without the other has little meaning. So as we near towards some of the end of our presentation, we'll spend a few minutes putting together the two, quality and cost. We'll spend some time putting the two together. As you've probably heard me say a billion times at this point, pricing doesn't matter if you don't also look at quality. What we care about is value, meaning we want the best quality for the best price. So getting the worst care at an affordable cost is not what we want. We want the right care at the right time at the right place. This graph plots the overall relative price and the corresponding CMS quality score for all of Kentucky's hospitals in the study. The axes show the US average price. So if you are above that, you are higher cost and vice versa. And the most common CMS quality score of 3. So if you are to the right or left of that vertical line, you are higher or lower quality respectively. What you want to be, and I think I've circled it, yes, is where the circle is, higher quality care at lower cost. But you can see here that there is little or no relationship between the price you pay and the quality you receive, which is what we've seen at the national level as well. What's really funny is I posted a picture of this in the background of an Instagram post last night without these labels, and somebody replied to my Instagram story saying, "This looks like you can't read anything from it." And I was like, that's exactly actually the point. There is little or no relationship between the price you pay and the quality you receive. Looking at the same information in a different way, as bars bucketed by CMS quality score, you can see that there is, again, little or no relationship between the price you pay and the quality you receive. For example, at Kentucky's hospitals, you can receive 3-star quality at very different prices, as is the case with these two facilities that I have the arrows pointing to. Alternatively, you can pay essentially the same price for very different quality. I don't know about you, but if I'm going to spend the same price, I definitely want to go to the 4-star hospital versus the 1-star hospital. And then, like I said, one of the new additions to this year's data is the Leapfrog safety grade on hospital patient safety, and they give a letter grade of A, B, C, or D. And you can see the same thing here, the same data with the same hospitals separated this time by Leapfrog grade. You can see very similar to those the CMS hospital stars. So to wrap up on some of the data, while our overall price is lower than the national rate, there is variation among hospitals in Kentucky and in Southern Indiana, not just within the state, but also within region cities as well. For the first time, outpatient prices in the Commonwealth are higher than the national rate. And again, similar to what we've seen before, there is little to no relationship between the cost and quality of care. Something I'd like to dig in a little more to, if we can get a hold of the data, is ambulatory surgical center prices relative to Medicare are lower than the hospital-based outpatient prices. And I did want to give an update on the RAND studies in general. RAND 5.0, the next iteration of the study, is currently being planned. And the RAND Corporation is currently recruiting employers to participate in this next round. And if you or your organization are interested, you can visit the link on your screen to fill out a contact form, or you can reach out to us as well. We've been partners with our friends in the Employers Forum of Indiana and RAND for a long time, and we can help make those connections as well. I have not heard any information on the timeline. Generally, every year to 2 years, we get a new iteration of the study. I don't know what they're planning for this one. And before we open up for Q&A, and I see we do have several in the Q&A, I can see that notification. I don't know what those questions are just yet. There are 2 items that if this work interests you, you need to know about. The first is SAGE Transparency. SAGE Transparency is a first of its kind tool developed by the Employers Forum of Indiana that brings together public and proprietary data on hospital pricing and quality, including the RAND data that we focused on today. The dashboard gives users free access to price and quality data for thousands of hospitals across the United States. It's an interactive, customizable dashboard which displays data from a variety of sources in an easy to understand way. I encourage you to visit the link you see on your screen and explore the wealth of information that our friends in Indiana have put together as a public service, really, for the nation. And I mentioned earlier, and I keep always straying away from this because I don't know the answer. It's a very hard answer. It's a very hard question. But I mentioned earlier the question of what is a fair price relative to Medicare to reasonably expect from our hospitals? The answer to that is very much open to debate. Is 100% of Medicare what Medicare would pay for the same services fair? Is 200%? I think we can all agree that some of the hospitals we've seen across the country with 400 or 500% is not reasonable. But beyond that, I think there's still a lot of debate that we have to have. The RAND studies have not traditionally focused on answering that question, as I think Jenny said in her opening remarks. But one of the tools that has just the SAGE Transparency tool that was just released, one of the tools on that is the National Academy for State Health Policy, NASHP, hospital cost tool, excuse me, not price, cost. That calculates the commercial break-even price with federal government data submitted by the hospitals. So marrying these data pieces together, whether it's RAND, whether it's NASHP, whether it's CMS or Quantros or Turquoise, it has allowed some organizations across the country to begin to narrow in on more specific numbers of what is fair beyond just comparing current relative rates to other states. there's really, we've got 9 minutes left. There's not nearly enough time to discuss that in the scope of today's webinar, but that question will be explored in December at our KHC Community Health Forum. So on December 6th, our quarterly forum will focus on a lot of the stuff we touched on today, on the transparency studies, tools, CMS rules that are changing the landscape of healthcare quality and cost, data and reporting and transparency. Details will be announced in the upcoming weeks with speakers and agendas and topics, but you can register now at the link on your screen. And I believe Natalie is putting it in the chat for me as well. This is a planned hybrid event. So we're still working out those details as well. But we hope that you can join us if you're interested in hospital quality and cost and price. So with that, I think we have probably about 5 minutes left for Q&A. I'll ask, I see Jenny's already come up on the screen. And if, I know you've been monitoring the chat. Are there any that have stuck out to you that you'd like to just tackle first?
Well, there are quite a few, Stephanie, and I addressed it a little bit. I typed an answer, but a lot of really good questions and feedback from the hospital community about the fact that, and there are different numbers that have been put in the chat about Medicare in Kentucky doesn't pay 100%. They pay, one chat said 80, one chat said 90% of cost, not charges. And the one thing that I put in my response is that is really good information. And what the RAND study has done, and Stephanie, step in with this if you want, is it's given us an opportunity to take data that doesn't necessarily take into consideration all the cost components that you may have in a hospital. So and I think Stephanie said this, we're really not advocating for paying 100% of Medicare or paying 150% of Medicare. What we are saying is transparency is important for us to kind of start the conversation. What is the right answer? And the National Academy of State Health Policy that Stephanie mentioned is coming up on their website, which is part of the SAGE transparency tool. They are digging into, as well as Turquoise, digging into all of that data that the federal government said that hospitals needed to list on their websites. So they're pulling in what hospitals are saying are, correct me if I'm not using the right word, Stephanie, charges. What you have out on your website is what a charge would be or a cost would be for a particular procedure. And so what they're doing is they're looking at that and they're saying, well, it looks like hospitals would break even at XYZ dollars. So what the RAND study does not do that, but what the RAND study has done is been able to help us start this conversation. And now with the federal government requirements that are in for hospitals to post their information, it's allowing us to continue to dig and have conversations. This isn't meant to be negative to hospitals, not at all. It's just meant to have a conversation as all of the multi-stakeholders in the healthcare industry to learn from each other. Like the fact that, this data released the spring of this year is a look back. So it doesn't include the entire COVID-19 period. So it's a look back at information because, Stephanie, one of the comments that was made is one thing is related to elective procedures were put on hold for several months in 2020. So there were a lot of losses in that area. Different staffing models apply in different markets, like between Kentucky and Indiana or in Kentucky and Tennessee, et cetera. But again, these are conversation starters that help us get to that piece of transparency. So I'm also looking at questions. I didn't type in an answer. It came near the end. Stephanie, one question is on the CMS quality score, is that based on the Medicare Advantage STARS rating program?
It's on the STARS program more generally.
Yes. And near the beginning, there were a couple of, what's the difference between relative prices and reference-based pricing? Totally different things, but do you want to take a stab at that, Stephanie?
How about you do that? You've worked a little more in that space than I have.
Yes, and I've not worked in it
I'm
in
just
a
the
lot.
data jockey.
Yeah, the reference-based pricing, and Mike Lorches was on the call. I don't know if he's still on the call. He might be able to help me here if I get it wrong, but reference-based pricing is going to be a negotiated rate that you're going to have a direct contract with an organization. A lot of times it is hospitals. That's where that's been started. It could be with another provider. So the relative prices are what, now you can explain that one, Stephanie, the definition of the relative price. We had that on the slide early on, but it's totally different than the reference-based pricing, from my understanding.
Yeah, so the relative price as it pertains to this study for the RAND studies is the allowed amount, the amount actually paid divided by the what Medicare would have paid using the Medicare algorithms for case mix and local wages and that kind of thing, what they would have allowed for that same service at that same hospital based on their algorithm. So if you have a relative price of 200% to make life easy, that means for every dollar that you would have paid to Medicare for that service at that hospital, you would have paid $2.
So I see that Suresh said, there he is, that he could answer that. I was trying to find him on here so I can give him permission to talk. Suresh wanted to answer that question, but now I'm not seeing him on the participant.
I think he might have had to hop off. I don't see him.
Oh, there he is. I see him. He moved up because he raised his hand.
Oh, gotcha.
Yeah,
Suresh, we have just a couple minutes left. Go ahead.
Yeah. Real quick, I can answer the reference versus relative because it is confusing. When the RAND created the relative price, they're not trying to necessarily compare the price of services paid in Kentucky versus Indiana versus New York versus Washington based on an actual amount paid. It's based on relative rates based on the amount of Medicare that's paid in the state. So you are not comparing apples to apples, but you're comparing Washington apples with Granny Smith apples in the sense they're related, but it's not a direct comparison. So that's the relative price, and Medicare takes into account the complexity of the case, the universities within the state, so on and so forth. A reference price is a price that is felt to be due to a fair market value price. And how that's calculated is very variable and somewhat controversial, but in general, there is a movement towards shoppable services that one price is felt to be a fair price, and therefore anything below it is good. The reference price is fair, and everything above it in a way could be too high. So relative prices are what the RAND uses. Reference price is an employee-based price that's trying to be set for a shoppable service.
Thanks, Suresh, for that
clarification.
That was really helpful.
Yes, I was looking to see if there were other questions.
It is 1 o'clock, so we are unfortunately out of time. And, you know, as one of our former board members used to say, leave them wanting more. Appreciate the robust discussion that seems to be happening in the chat and in the Q&A. I will send out resources after this meeting concludes, and I will send out the slides as well with those links, and hopefully you all can help continue this conversation with us in December. So thank you everyone for joining today, and we will see you soon.
Thank you. Have a great day, everyone.
Thank you, everyone.